Hey everybody, I just want to give you a lecture on chapter 10 so that I can pull out some of the things in this chapter that I think you will need to know. So chapter 10 is the assessment of high-risk pregnancy. See these twins here in this picture. If you are a twin pregnancy, you're automatically considered high risk among other conditions, but we're watching those moms and babies really closely. Okay, looking at the types of high-risk pregnancy, these are grouped into broad categories including biophysical factors, psychosocial, sociodemographic, and environmental. Biophysical is, of course, anything related to the body of the mother or the fetus. Genetic problems, nutritional risks, especially for adolescents or underweight mothers, and then also overweight, right? So obesity is another type of nutritional risk there. Other medical conditions, for instance, if the mother has heart disease or a heart condition that might put her at risk. Of course, our circulatory system goes under many changes and is under a lot of stress in pregnancy, delivery, and postpartum because of all the fluid shifts and pressure changes. So that would be one example of that. ABO-RH status of the mother and or the baby if it's known at that time. And then other past obstetric complications could put the mother at risk for future pregnancies, considered high risk, meaning we're going to watch her a lot closer during her pregnancy. Psychosocial factors could include substance abuse, so smoking, caffeine, alcohol, drugs. I don't know if I mentioned to you yet, caffeine, of course, is not like a controlled substance, but if taken at high levels, above 200, I believe it's micrograms, it's considered a risk for miscarriage. You're at an increased risk for miscarriage. So we don't say that you have to cut off caffeine cold turkey, but we do recommend that those in early pregnancy limit it. And then later in pregnancy, kind of on the same note, we want mothers to know that caffeine does cross the placenta. Your baby can get dependent on caffeine the same way you can, and it could set the baby up for any of these dependency, like with smoking, it'd be nicotine. Caffeine is one, alcohol, and other types of drugs could all set the baby up to be having withdrawals in the first couple of days and weeks after it's born, and of course that's very sad and really hard. Why would we want to do that to our babies, right? We don't want to do that to ourselves, and certainly wouldn't want to do that to our babies. So just know babies can be born caffeine dependent as well. They can have withdrawals. It also does pass through the breast milk some, so if you have, coffee and then you breastfeed, your baby might be up for a little bit, maybe a little bit jittery, things like that. Another couple of things while we're on this topic is that smoking can cause fetal growth restriction, basically inhibits blood flow to all parts of the body while you're smoking, but one of those parts, of course, is the placenta. So your baby can not be getting enough nutrients and blood flow, oxygen and things to grow at the normal rate if you are smoking. And then alcohol can cause fetal alcohol syndrome, and we don't know at what level that happens. So the recommendation is just to not drink any alcohol. We just don't know when that threshold is crossed to the point where fetal alcohol syndrome will be the result. There are other psychosocial risk factors that aren't listed here. This is other types of emotional distress, disturbed relationships, inadequate social support, any unsafe cultural practices too. So this is, we're looking kind of at the whole person. In this case, even mental illness could be part of this factoring in as well. And then sociodemographic factors could be a low-income family, lack of prenatal care, the patient's age. So less than 16 and over 35 are high risk automatically. Immigrant status and the patient's ethnicity. So like we talked about last week, some African Americans are at a higher risk of mortality and morbidity in pregnancy, and we don't really know why, but they also have, African Americans have the highest rate of preterm birth. So some things that we're watching for automatically there. Environmental factors could be in the workplace or the general environment if she's being exposed to chemicals like lead or mercury. But sometimes other things too, like maybe anesthesia gases. Labor and delivery nurses are exposed to Pitocin and Cytotec and other induction medications and all types of medications really, but regularly. So that could be a risk as well. Something to watch for at least. So infections to like communicable diseases and things like that. So let's go on. Okay, ABO compatibility and RH incompatibility. We're looking here at the mother's RH status, and the test that we do that's associated with this is called the Coombs test. It determines compatibility, and it's basically testing for antibodies that could potentially harm the growing baby because it perceives it as a threat, as a foreign body that it needs to basically attack as it would any other foreign body, right? So the Coombs test we test early in pregnancy, and it can cause fetal hemolysis. It's basically attacking the baby's red blood cells. You can do an indirect Coombs test that tests for the antibodies in the serum, the mother's serum. You can do a direct Coombs test once the baby's born. We're testing the baby's Coombs test as well to make sure there's not incompatibility on the baby's side because it can cause jaundice after the baby's born. So you can have sensitization in either direction, but what would happen is if the mom is RH negative, as in this photo, then there is a strong chance that she might be sensitized to her baby's positive RH blood. However, this doesn't affect her during her first pregnancy with an RH positive baby. That first time, the baby grows and does fine, and she may not notice anything. But by that time, and by the time she gets pregnant again, her body has developed these antibodies against the RH positive blood cells. So then for her future pregnancy with an RH positive baby, it could cause hemolytic anemia and even death or miscarriage for the baby. So it doesn't affect necessarily her first or current pregnancy, but it does affect future pregnancies. It's when the mother is RH negative and the baby is RH positive, we are going to need to give that mother RhoGAM when she's about 28 weeks pregnant. At this time, we don't know the baby's blood type, right? We haven't done testing to test the baby's blood type, but we know mom is RH negative and there's a chance that the baby could be positive. So we go ahead and give RhoGAM. And then after delivery, if the baby's blood type is a positive blood type, then we're going to give her another dose of RhoGAM. If the baby is a negative blood type, we don't need to give it because there's not a chance of sensitization there. Let's look at the next slide and see. Okay, So here we go, illustrating the first pregnancy in an Rh negative mother. The baby is a positive Rh type. So then after delivery, the mother is sensitized to these Rh positive cells, and it's going to think it needs to attack any other times an Rh positive cell comes, into her body. So then for the second pregnancy, she's got these antibodies against the Rh positive cells, and they cross the placenta and can cause anemia, hemolytic anemia in the baby. Here, the condition is called erythroblastosis fetalis. Okay, so the leaking of fetal Rh positive blood into the Rh negative mother circulation would cause this. So this doesn't necessarily happen with every pregnancy, right? But it could happen on micro levels that we don't see. It could also happen with any trauma. If there's a placental abruption, if there is some sort of accident, or anytime that she might be getting in a car accident or have some other sort of abdominal trauma or anything, we're going to give her RhoGAM. Also, in the case of, say, any invasive procedures that we might need to do, we're going to need to give her RhoGAM as well. Okay, antepartum testing and biophysical assessments. There are many types of testing in your book that I recommend you review. However, we'll talk about a couple of them here today and a couple of them other times. So first, the daily fetal movement count, also called the kick count. This is simple, accurate, and a good test for moms to do. You are looking for 10 movements within a 2-hour period. Those movements could be flutters, rolls, kicks, turns, stretches, whatever you can sense that the baby is doing. Any movement at all. That if that happens 10 times within 2 hours. If you don't feel like your baby has moved within 12 hours, then that is a reason to go to the hospital. Now, the baby does go through sleep cycles. Could also, its activity could be affected by any medications or drugs that the mother is taking. It also can be more difficult to sense if the mother is obese and is not able to feel those movements as strongly. So those are just some factors to consider, but a positive fetal kick count, something that we consider reassuring, would be those 10 movements in a 2-hour period. Then we would give recommendations to her to kind of track them better or wake the baby up. But if a mother thinks that the baby hasn't moved in 12 hours, then definitely would want to be seen. Okay. Another type of testing is called the NST. It's the non-stress test. This is very common way of evaluating the status of the baby. We're going to be talking a lot more about fetal heart rate rhythms next week. But you can see here on the tracing this nice squiggly line, and then it has big squiggly hills kind of intermittently. The squiggly line where it's flat is called the baby's baseline, and we're looking at that baseline number. We want it to be between 110 and 160 beats per minute, and this amount of squiggling is very good. We call that moderate variability, and that is a sign that the baby is adequately oxygenated at that point in time. The hills intermittently are called accelerations. So the baby's heart rate is accelerating, and if that happens at least twice in a 20-minute period where the heart rate goes up at least 15 beats for at least 15 seconds, then that is called a reactive NST, reassuring NST. So we are doing this often. We always also put the bottom monitor on, which doesn't really show in this picture. Those little spikes there on the bottom don't mean anything. Doesn't really look like they had the monitor on her at that time. But if there are any contractions, we're definitely watching the correlation between the two. If a mother is before 32 weeks, then the accelerations are 10 by 10. So we consider it an acceleration if it's a little smaller, and that's fine. If it doesn't meet those qualifications, then we would call it non-reactive. Okay, so a reactive NST is a reassuring baseline with at least 2 accelerations in 20 minutes, and a non-reactive does not meet those qualifications. Okay, a contraction stress test is similar to the NST, the non-stress test, except it is in the presence of contractions. Oftentimes we would do this to test whether the baby could tolerate labor, basically. It's not as common because it's more time consuming, it's more expensive, it's more invasive because we are causing contractions. So usually if we're doing a contraction stress test, it's more in the context of an induction and we're just watching the baby closely as contractions are begun. But if it's needed, it is an option. So contraction stress tests could be done by inducing contractions with oxytocin, basically, and nipple stimulation does produce naturally oxytocin in the body, which can cause contractions. So that is one way to do it. You know, we would ask the patient to do it themselves or a significant other. Nipple stimulation could also be done with a breast pump if needed. But oxytocin stimulated is another method that would be done only in the hospital. She would already be, you know, admitted with an IV and kind of getting things going, that we would be giving oxytocin in the form of Pitocin to the mother. The interpretation is the same. We're just watching closely for concerning heart rate patterns. Again, we'll talk more about that next week, but it can provide a warning of fetal compromise earlier than an NST because it's putting, you know, simulating the stressors of labor and could kind of give the provider a little bit better indication of whether that baby could tolerate labor. Of course, we're not going to be doing a contraction stress test if a vaginal delivery is contraindicated for any reason. So that would be, you know, preterm, or if there's placenta previa present, anything like that. Anything that would contraindicate a vaginal delivery anyway, we're not going to be doing the contraction stress test. All right, that's it for this kind of last chapter, and this is just kind of your overview for next week. Just a reminder, this is also going to be in your announcements. But remember, we have a quiz next week, and then the following week we have your first exam. So we're going to be posting study sessions and just, you know, be studying because it comes quick and then it feels like there's lots of tests right after that. So happy studying, and I will see you soon.